Good morning, all of you. Good morning, all of you. Today we are going to discuss about the basic principles of periodontal surgery. So the contents of the basic periodontal surgery is introduction, surgical goals, objectives, indications, contraindications, general surgical principles, medical history and physical status, diagnosis and treatment plan, aseptic surgical technique, anesthesia and pain control. And tissue management, that is the management of flap, in which we are going to cover the incision, flap preparation, flap design, flap retraction, open flap debridement, and about the flap positions. Then we are going to discuss about the hemostasis, suturing, wound management. In wound management, we are discussing about the periodontal pack and post-operative instruction. So that's it for the general principles of periodontal surgery. So first of all, a brief introduction. What happens in the general principles of periodontal surgery? It basically composed of the periodontal disease and the treatment of the periodontal disease. It encompasses a vast array of non-surgical techniques which aimed at the elimination of infection and inflammation to establish a healthy periodontium. The periodontal surgery is an irreplaceable therapeutic modality that must be mastered to effectively to treat the dental health problems and that many patients have. So what are the basic objectives of the principles of periodontal surgery? What is the periodontal surgery? Why we are going to do about the periodontal surgery is basically the basic main idea of doing the periodontal surgery is accessibility. Accessibility to roots and alveolar bones, which basically by the flap we can enhance the visibility and increase the skilling and root cleaning, less tissue trauma, and the modification of the osseous defects, establishing a physiologic architecture of our tissues through regeneration and resection, and augment the rich defects. So, to augment the rich defects. And the third aim is to basically repair or regeneration of periodontium, the lost periodontium, pocket reduction. Because of the improved accessibility, we can reduce the pocket depth and enhance the patient maintenance by the patient and therapist, improve long-term stability of the periodontium, and provide acceptable soft tissue contours. It enhances the plaque control and maintenance, improve the aesthetics. So what are the indications of periodontal flap surgery? Basically for the accessibility for proper scaling and root planing, because the plaque and calculus which are present in inaccessible areas, which it can be removed with the proper flap elevation, and it can remove the etiologic factor which can cause the periodontal disease. Establishment of the morphology of the dentogingival area and conductive to plaque control, pocket depth reduction, and the correction of gross gingival aberrations. Shift of gingival margin to a position apical to the plaque retaining restoration and to facilitate the proper restorative therapy. So these are the indications of the flap surgery. And what are the contraindications? Contraindication, as we all know that the oral diseases are the periodontal disease, especially it is related to systemic disease, and there has been proven evidence for the two-way communication of the disease like diabetes and cardiovascular diseases. So basic the contraindications are uncontrolled medical condition such as unstable angina, uncontrolled hypertension, uncontrolled diabetes, myocardial infarction, or a stroke within 6 months, poor plaque control, high caries rate, unrealistic patient expectations or desires, Unrealistic patient means like the patient has great free mobility and patient really want the tooth should be immobile. It cannot be happen because when once the periodontium is lost, we cannot regenerate unless and until the defects are vertical. And so you do not carry the parental surgical procedure in unrealistic patient. Expectations and desires, you need to confirm the expectations and desires of the patient, like patient what want. And the success of the parental surgery is basically the poor plaque control. Poor plaque control means if the patient has undergone the parental surgical procedure but not maintained the proper oral hygiene in the maintenance phase, you cannot indicate for such patient for parental surgery because it will fail. Hospital parental surgery. What happens, what is the purpose of hospitalization? Basically what happens, like the patient's general contraindication says patient general condition is not that the patient can undergo surgery in the dental setup, so we need to do the parental flap surgery in the hospital setup to protect the patient's special needs and patient's special demand, like patient is very apprehensive, so such type of parental surgical procedure is indicated in the apprehensive patient, and patient is convenient, and the length of hospital stay is 48 hours, and patient is admitted early in the afternoon and preceding the day of the operation. You are going to check about the physical examination and complete hemogram. Means you are going to check the BP, the pulse rate, the total leukocyte count, differential leukocyte count, hemoglobin, and even the anticoagulant profile. The patient is on the warfarin or anticoagulants or previous history of like any medical disease and medical consultations. You are going to have with the medical consultations. Then the pre-medication and anesthesia, operation, post-operative instruction at the hospital, first post-operative visit, post-operative office visit. You need to check all those points during the consideration for the general principles of parental surgery. If the patient is very much apprehensive, you can pre-medicate with the antihypertensive agents. If patient is like have a high BP and you can use the alprazolam or midazolam to reduce the anxiety, and the operation theater should be proper autoclaved and proper sterilized, and post-operative instruction is given. Now the general principles of parental surgery we are going to discuss in brief. First of all, the medical history and physical status of the patient. See, what happened, the need of the medical history is a key most important point in the any success of the surgery. You have to take the all complete thorough medical history. It's basically to identify if the patient has any potential health problems, so that can occur suddenly during the procedure. So we have to know that the what emergency drugs we have to keep during the performance of surgery. Relevant aspects of the medical history. In addition to the patient history, a general assessment of patient's physical characteristic for abnormalities in gait, in body movements, body symmetry, posture, weight, skin, eye, speech, ability to think clearly should be included because this will give the general status of the patient. And what happens, it will also gives the patient's ability to cope up with the surgical procedures. So, and then what is your diagnosis and treatment plan? First of all, what is there is any need of the periodontal surgery, the diagnosis should be made because the periodontal surgery must be integrated into a well thought out and organized sequence of treatment that is based on the previously determined etiologic factors, diagnosis, prognosis, and patient desires. Now, the aseptic surgical treatment. Aseptic surgical treatment means a unique aspect of the periodontal surgery. Surgical team must follow the aseptic surgical technique to ensure the incidence of post-operative infection remain as low as possible. You, use PPE, personal protective equipments like surgical caps, surgical masks, and surgical gloves. Patient draped with sterile towels. Use of sterile, saline, and water irrigation, and including the irrigation through ultrasonic hand devices. Surgical instruments must be properly sterilized. Uh, they should be properly autoclaved. We can use autoclave, hot air oven, sterile coverings over the light handles. Patient preparation should be done. Pre-surgical rinse, you can do patient with the 0.12% of chlorhexidine for 30 seconds, which will provide the significant reduction in intraoral bacterial load. Because as we all know that the parental pathogens, they are the tissue invading enzymes. They provoke the tissue invading enzymes, and the oral bacteria can run into your main bloodstream. So pre-surgical rinse always helps the transmission, to stop the transmission of oral bacteria into the main blood stream. So which prophylactic antibiotic you are going to use? So anesthesia and pain control. So you can use prophylactic antibiotic in the case of like subacute bacterial endocarditis patient, and you can use antibiotic where the chance of infection is very high. So in such cases, where patient immunosuppressive, so in such cases you can use the prophylactic antibiotic. Anesthesia and pain control. Control of physiological mechanism of pain is the main function of local anesthesia, whereas control over the psychological factors that influence the interpretation of stimuli as painful is a function of conscious sedation. Pharmacological and physical properties of anesthetic agent determines the effectiveness and duration of the action of anesthetic. Means what happens, you can use the long anesthesia also, and you can use the short term anesthetic agent also, whatever you want to do. Like for the in allergic patients, allergic patients, you can also use the anti-allergic components. So what is the potency, onset of action, and duration of action? These are the like key factors to select the local anesthetic agent, and it is the important property which is important to the dental practitioner. So important aspect of pain control is providing long-lasting anesthesia during immediate post-operative period. Instrument used in the parental surgery. Surgical procedures is involved in the parental therapy, often involved in the following measures: incisions and excisions, deflection and readaptation of the mucosal flap, and removal of adherent fibrous and granulomatous tissue. What happens? You're going to use the parental knives, or you're going to use the number of blades like 11, 12, 15, and 15C. All these blades we can use to make an incision, and you can use the parental knives also. So you have to use the parental elevator for the reflection of the flap, and for the removal of the soft tissues and granulomatous tissue. We can use the tissue nippers and scissors and rongers. Then for the scaling and root planing, we are going to use the scalers and curates. Removal of the bone tissue, you are going to use the bone rongers, chisels, and files. Sectioning burrs are also there if there is any need of hemisection or root resectioning. Suturing, there will be sutures and needle holders, and suture scissors. For the plastic instrument, for the manipulation of your parental pack, and put it on the area which has been undergone surgery. Set of instruments should have simple designs. As a general rule, number and variety of instruments should be minimum. Instruments can be stored in sterile, ready to use packs or trays. Instruments should be in good working condition. So instrument tray basically composed of mouth mirror, graduated parental probe, the key instrument in parental flap surgery. You are going to measure the parental pocket depth with the parental probe, explorer, handle for disposable surgical blades like Bart Parker handle, mucoperiosteal elevator, and tissue retractor, scalers and curettes, cotton pliers, tissue plier, tissue scissors, needle holder, plastic instruments, hemostats, and burrs. Additional equipment may include syringe for local anesthesia, syringe for irrigation, aspirator tip, physiologic saline, draping for the patient, surgical gloves, surgical mask, and surgeon's hood. So now just come to the tissue management. First of all, tissue management, it includes the flap management. Surgical access to the various components of the periodontium begins with the well though out incisions. Different surgical techniques involved a variety of incision design. Regardless the type of incision which is used by most of the surgeon, they should have used the sharp cutting instrument because the blunt instrument can produce the ragged margins and have difficulty in healing. Knife, minimal and smooth movement and minimal drag to the tissue. External bevel incision, we can use the external bevel incision. External bevel incision means the incision which is coronally directed. It is basic indication is used for the gingivectomy, gingival overgrowth procedure, crown lengthening procedure, and gingivoplasty. Kirkland knife, Orban's knife, scalpel blade, 11B, 15 number blade you can use. Now the second incision is internal bevel, means the cutting edge. It is placed apically towards the crest of the gingival margin, and it does not start from the gingival margin, not from the gingival sulcus. It should be always away from gingival margin, 0.5 to 2 millimeter. So basically it is used in the modified Whitman flap, it is used in the curettage, crown lengthening procedure, gingival enlargement, excisional new attachment procedure. The scalpel blade 12 number, 11 number, 12B or 12C. The third incision is circular incision, the clavicular incision, apically directed, placed in the gingival crevice and directed towards the alveolar crest. When the preservation of gingiva is critical, as in of aesthetic areas of minimal keratinized tissue, and also used in the guided tissue regeneration procedures. So the blade which we can use in this is 11 number blade, 12 number blade, 15 and 15C. Releasing incision. It is also called as vertical incision. These are the incision which is perpendicular to the gingival margins at the line angle of tooth to increase the access to allow the apical and coronal positioning of the flap. Scalpel, 11 number of the blade and 15 number of blade. Thinning incision, internal or undermining incision extending from gingival margin towards the base of the flap to decrease the bulk of the connective tissue on underside of the flap. Palatal flap, distal wedge procedures, internal bevel gingivectomy, bulky papillae. And for the scalpel blade, 12, 12B, 15 or 15C. So thinning incisions can be used undermining. It extends from the gingival margin to the base of the pocket or base of the flap. So basically it is used in the fibrotic gingival enlargement. So you can use the thin flap. Now the cutback incision, the small incision which is made at the apical aspect of the releasing incision and directed towards the base of the flap. So basically what happens, the pedicle flaps that are laterally positioned and the scalpels which used is 11 and 15C. The next is periosteal releasing incision. Incision at the base of the flap severing the underlying periosteum to release the flap tension and allows the normal coronal advancement of the flap. So it is used for the 15 number and 15C. And basically the vertical releasing flap, it basically decreases the tension in the coronal movement of the flap. So you can see the picture which represents the external bevel incision. It is the right angle incision. You can see here external bevel incision. The cutting edge is towards the gingiva. Okay, it is coronally directed incision. It can be start from here 2 to 3 millimeter away from the gingival margin, coronally directed. So external bevel incision can be angulated. It can be straight with the right angle incision. Now the circular incision. Circular incision. So the second incision is your circular incision. So it is given in the gingival sulcus. You can see with the 15 number blade or 11 number blade, the circular incision, this incision which is given in the gingival sulcus. And this is the internal bevel incision. In internal bevel incision, you can see it is always directed 0.5 to 2 millimeter away from the gingival margin, and the cutting edge is towards the crest of alveolar bone or gingival crest. So basically, it is the aim of the internal bevel incision is to remove the pocket lining also and to provide the primary thinning of the flap. Now the flap preparation. Flap preparation means is a surgical flap is defined as the separation of a section of a tissue from surrounding tissues except at its base, full thickness or mucoperiosteal flap, partial thickness. Full thickness on mucoperiosteal flap means whole of the mucosa along with the periosteum is elevated from the underlying bone, and partial thickness means the flap is elevated, leaving the connective tissue covering the bone or periosteum covering the bone. Flap design based on the principle of maintaining an optimal blood supply to the tissue. There are two basic flap designs: those with vertical releasing incisions and without vertical releasing incisions. So, alteration in gingival circulation resulting from various parental flap designs, it is studied in humans. The major blood supply to the flap was found it exists in the base, traveling in a apical coronal direction. Based on the basically the blood supply, you are going to design the parental flap because flap needs the blood supply, and it also determines the greater the ratio of flap length and also determine the ratio of the flap length to the flap base, greater vascular compromise at the flap margins. Flap reflection. So, full thickness flap is elevated using sharp periosteal elevator directed beneath the periosteum, always kept against the bone. We use the periosteal elevator to reflect the flap. So what happens basically, the instrument is pushed in between the flap and the bone, and it was always kept against the bone. Papilla is reflected first, followed by the marginal gingiva, working across the anterior posterior direction of the incision, reflecting until the flap margin has been freed from the tooth, alveolar, bone, or both using the gentle force. Inadequate flap reflection results in the greater tissue trauma to decrease the treatment efficiency. So we first of all the interdental incisions, interdental flaps are reflected, and then the incision is carried out anteriorly and posteriorly so as the periosteal elevator. So we use the periosteal elevator anteriorly and posteriorly to carry out the parental flap reflection. So what happens if the flap is inadequately reflected, it results in greater tissue trauma and decreased treatment efficiency. So you are going to decrease the treatment efficiency if you're not going to reflect it properly. And what is the aim of the flap is